history of total cessation of urine for 3 days. 3 days he had not a single drop of urine he able to pass. Vomiting for 3 days and severe weakness for 3 days. That was his presentation. Then, history of his past illness. He was patient of bilateral uterine stone, known case, and under treatment of Sarsolimula Medical College Hospital and waiting for admission. But investigation done before this disease diagnosed, X-ray QAB, IVU, serum creatinine. At that time, bilateral radiographic status on ureteric lines, IVU bilateral uterine stones with bilateral hydrolytic necrosis, serum creatinine was 1.2 mg. When he was moving with this stone and waiting to get admitted into Sarsolimula Medical College Hospital, but due to lack of facilities, he was not able to get admitted. And suddenly, he developed this problem. When he came to us, on examination, he was very ill looking, he was dehydrated, bladder was empty clinically, and pulse was 120 per minute, blood pressure was 20-25 minute, respiration 28 per minute, no edema, no puffy face, no other abnormality detected. Now, investigation done on admission. X-ray QAB bilateral uterine stones, random blood sugar 5.4 millimole per liter, urea 174 milligram per dl, and serum creatinine 15.1 milligram per dl. That was the creatinine when he first admitted. And serum electrolyte 140 millimole sodium and 3.9 millimole potassium and chloride something 104. And emergency operation done. We just arranged this operation within 2 hours. In my department, though academically I have got no support, but technically we arranged a very good support, including my very good anesthetic team. And that technical support we take from our OT staff, and we arranged the operation within 2 hours. And we took about 3.5 hours to do this procedure. As we have already mentioned, this sort of problem is an emergency, and thing is that we can go for open ureterotomy. Again, in this patient, very bulky, and it is very difficult to do bilateral ureterotomy. And only standard procedure practice all over the world, even in England, America, all fast world, this is the latest procedure, which we have done. The thing we failed to use, that is the laser. Only the energy we failed to utilize that because it is not available. But everything done, and I think many things, many operations in this hospital done which are world standard, and principals are and all other gynecological department also they do some work which is international standard. So it is of that standard which we can offer from our hospital. And this is the second case in hospital I have done. Another housewife from Borishal, he came and we did that case also in this way. And this is the patient operation table. And when he was discharged, and now the thing is that we want to show the procedure how it is done, how this procedure is done. As we have already seen the figures, so if you go for endoscopic view, then what are the things you will get? We have got all these instruments over there. So endoscopically, we just enter into the urethra. That is the ureteroscopy and stone clearance, the way what we do it. That is the urethra we are going through. That is the view. And then we cross the verumentanum. That is the verumentanum. Then this is the bladder neck. This is the bladder neck. This is the verumentanum. This is the verumentanum. And this is the bladder neck we are reaching. This is the bladder neck, and this is the ureteric orifice. This is the one ureteric orifice, and that is another ureteric orifice here. And this is the ureteric orifice, and this side stone is impacted. There is the impacted stone in the urethra, and the guide wire. We have got this guide wire. We are passing this guide wire first. Safety guide wire. This guide wire will guide me where I am going. So this guide wire first. Then another second guide wire. This guide wire passing the obstruction. So pus is coming out from the ureter, and that is the stone within the ureter. This is the stone within the ureter, and the pneumatic probe will just go, and this pneumatic probe will break the stone first. This is the unimetric probe. We have got that probe, and we have got probe also with us. And this probe will break the stone, but guide will remain. That guide will always remain. And this probe will break the stone. That is the grasper. That is the grasper we use to take the stone out. That is the grasper. And dormier basket. That is the dormier basket. Dormier basket in use. It is holding all the residual stone and taking it out. That is the dormier basket we use. And finally, after all this procedure, introduce the stent. This stent is going over the guide wire. That is the visa stent, double the stent getting in. So it will go one end in the kidney, another end will be in the bladder. That is upper J and lower J. And I think this is the total thing we have just done. Now the floor is open for any question, any query. And even a question to this gentleman who is with us. And during procedure, what we face that I want to explain in the right side, and I would like to show you the X-rays. We will get the X-ray of the gentleman, and when he did his IVU, two stone, one impacted here, another impacted here, and whole ureter and kidney. At that time, kidney was normal, so whole dilated ureter and both ureter and kidney dilated, and it is shown here. If anybody comes close, you can see dilated both ureter and both kidneys. And after removal of the ureter, he is having bilateral renal stent. Now he is having both kidney. He is having bilateral stent. That is the stent he is having now. He is having two stents, two kidney, and he is passing urine. And one thing we fail to do, this side we just break and take the stone out, but that side there are two stones. One stone we just take out and place the stent, another stone pushed back into the kidney during the procedure. So that stone is there. Yesterday we have crushed that stone by our stone crush machine, ASW machine. Now that stent will remain another 3 weeks, and then we will take both these stents out, and ultimately he will be relieved from this problem. And this in short. Now if you want to talk with your patient, how he is feeling, what was his condition? কি সমস্যা ছিল আগে যখন আসে তখন কি সমস্যা ছিল?
তখন আমার প্রচন্ড ব্যথা ছিল এবং খাওয়া দাওয়া হতো না, ইন্ডিয়ান ব্যাগ হতো এবং
পেশাব বন্ধ ছিল কিনা?
3 দিন ধরে প্রস্রাব পায়খানা বন্ধ ছিল।
এখন কি রকম আছে?
এখন আর ভালো আছে।
যদি কোনো প্রশ্ন থাকে আমরা আমাদের জিজ্ঞাসা করতে পারি, আর আমাদের এই টোটাল ডিসকাশনে যদি আমাদের কোনো কোয়েরি থাকে, কোনো জানা থাকে, we have to look at the discussion.
The process of this stone and how we can prevent.
Now that is another question from sir. That is a very small question. This question is also from everybody. That how this stone, why this stone forms, how we can prevent it. Actually, number one answer exact cause is not known. Number one. Number two, there are some investigations and some suggestions that there are some diets, there are fluid mainly. Diets now it is not that much counted. It is the fluid, it is the environment, it is the occasion where sometimes it produces some environmental, that is support where stone is formed. So there are stone formation is more. And there is hot environment, water intake is less, and some calcium containing, oxalate containing foods also responsible. But nobody can tell with this procedure you can prevent your stone. Only thing is that if you can take plenty of water, plenty of fluid, you will flush out system, there is less possibility of development of stone. But there is no pinpoint answer 1, 2, 3 or 5 that this is the answer and that will give you relief. No. The thing is that you take plenty of water, flush out your system, chance of stone formation is less. That is the advice. And in that case, many people ask how much fluid I shall take. There is another burden for us. Somebody, one of my patients advised to take fluid. He was taking fluid, sleeping his sleep, disturbing his sleep as well as family sleep. All time he is in that problem. So that is another problem. So take plenty means you take water, optimum water, take it more but not that the whole night will be there. Any question?
Is there a relationship with food tomato? With this food tomato?
Actually, with tomato I have got no idea whether tomato is directly related for or responsible for this kidney stone. But somehow it is related with some other stone in other parts of the body. But for kidney, I have got no information. For kidney stones, there are varieties of stones, but especially for kidney and this tomato, how much responsible, I don't know. If anybody know, you can just help me and help the audience to know that. But to me, specifically tomato, I don't know. I have got no report or any information, especially for tomato. But there are some another important advice. We just not take the stone out. After taking the stone, we send this stone for analysis.
Yes.
There is laboratory, and after analysis, we will find out what type of stone it is, and then we correlate what type of food can aggravate this sort of stone formation. And that type of food usually we advise not to take. And that we advise. That this facility is now available in our country. There are 3 or 4 centers in this country where we can go for stone analysis.
There is chance of recurrence of this.
Definitely, sir. Very important question. Another chance of recurrence. Now we have got one leaflet with us. Once we treat the stone patient, there is written information to the patient. This is not your final treatment, and this is not guarantee that you will not never develop a stone. It is information that very chance of development stone in rest of your life. So you take care of yourself, avoid food, which you get report from the stone analysis. Definitely there is chance. And that is information given to everyone. One stone, chance of always stone. And that should be in your back of mind. Otherwise, you will suffer from stone again. Any questions?
Yes, there are a lot of questions.
Sir, please. Sir, please.
The first question is that he was anuric for 3 days. 3 days, and his creatinine was 15. You have done it with using some anesthesia to this patient. So, was that logical, or some other options could be done for this patient?
Now the thing is that
What is the comment of the anesthesia? With a 15 milligram of creatinine, and you have done it under anesthesia, and what should be the option, other option for this patient?
right. So I think it is anesthetist, and I think with that item, when I admitted that patient, I just talked to our anesthetist. So whether I shall get in this patient, when you swallow, you have to pass it out. That's why before swallow, I just talked with that gentleman, Professor Razaul Islam, whether we should go for that, and he agreed. I don't know why he agreed. Now you will explain.
Thank you, Junior Rahman, for his excellent speech.
Other question also.
Sir, I want to
Now, the serum creatinine is 5, and urea is probably more than
174 milligram.
At this time, at this level, usually the patient presented with neurological and cardiovascular manifestation. That is the acute pulmonary edema, or the patient may have encephalopathy, uremic encephalopathy at this level. This patient, I think, is fortunate enough. And acute manifestation. The patient would present with a encephalopathy, but the patient had not so.
From anesthesia and the method of
What
anesthesia.
is about the anesthesia?
Yeah. Otherwise, you can take this one.
Hindi bale.
Hold.
হচ্ছে কি যে অবস্ট্রাকটিভ ইউরোপ্যাথি যেটা অবস্ট্রাকটিভ এটা সাধারণত রিভার্সেবল। সাধারণত অবস্ট্রাকটিভ ইউরোপ্যাথি যেটা অবস্ট্রাকটিভ ইউরোপ্যাথিতে যেখানে ক্রিয়েটিন লেভেল বেশি এবং ইউরিয়া লেভেল বেশি, একটা জিনিস ছিল কি এই দুটো জিনিসই খাট, কিন্তু ইলেকট্রোলাইট লেভেল কিন্তু নর্মাল। ইলেকট্রোলাইট লেভেল নর্মাল থাকার জন্য ইলেকট্রোলাইটের যে কমপ্লিকেশন এগুলো ছিল না। আর আমরা অবস্ট্রাকটিভ ইউরোপ্যাথি থাকে আমরা যদি মনে করি যে এটা অবস্ট্রাকশন রিলিভ করার পরে এদের ইউরিয়া ক্রিয়েটিন লেভেল কিন্তু ফিরে আসবে।
How do you suppose to it that after 3 days you will be back his kidney function back? But in this situation, probably the option is you have to do a percutaneous nephrectomy. And then if the kidneys start functioning, then probably you go for it.
Yes, sir.
That is the option.
না এই পারফিউরিনাস নেফ্রোস্টোমি এই একটা
আমি বলতেছি স্যার,
একটা অপশন আছে, একটা অপশন আছে।
And the important issue is that if this patient would be anuric further, then you have to do dialysis. But you had no facility for the dialysis. Then why you opted for such a surgery here?
Yes. Now, sir,
What is your logic?
sir, I got question of my principal, sir. Definitely, one option is peritoneal nephrectomy.
Under local anesthesia,
Under local anesthesia, we can do it. Definitely.
you do it, you will
Definitely.
be passing clean, then you do the
Definitely. But in that particular case, percutaneous nephrectomy, it needs some ultrasonal support, and it is possible only in case of dilated system. In case of non-dilated system, to put a stent,
kidneys are dilated.
definitely. But we urologists, we feel that percutaneous is more traumatic than periurethral, and because it is a natural process. So initially we were not in a mind to take the stone out. Initially we were in a mind to put the only stent bilateral, like you said. That was our motto. But the stent was passed so nicely both sides. Then we decided that whether we can offer these sorts of treatment now. Sir is very much correct. That is another option. But that option, we have facilities. We are not having that. We have got that ultrasonal puncture line, which is not available. We have not that contrast to dilate the system and see and puncture. That is another technology which is not available in our setting. That's why we avoided that one, and we chose the system which is feel comfort, which we use here. That's why that procedure we did not take, and we have gone through our known ways, which way we know very better. That is the answer of question of this question.
Next question is, next question is probably you show us the definition of anuria, but I think the definition of anuria has been changed, and that has been changed. It has been changed, and I think I don't know whether you are oriented to use or some mark and highlight on the changes of the definition of anuria, not the complete decision, but there is a change of time and there is a change of
That is,
amount.
urine formation is there, but urine is not passing at all. Complete anuria. Obstruction is there and urine is not passing. But urine formation is there. Actually, polyuria and oliguria. Oliguria means when the
Less than some amount.
less than 400 ml. 400 ml. এর যদি নিচে হয় তাহলে আমরা বলবো 400. যাই হোক 400 করে in some books it is
Yes,
written as
yes, very much.
400, but some books it may be written as 300. 300 এর নিচে যদি যায় তাহলে আমরা বলবো this is oliguria. And complete suppression যেটা সেটা হলো anuria.
Sir is very much right. I think sir is very much
Anuria.
enriched with recent knowledge of anuria, and I just respect with that knowledge. We will learn it from sir immediately. Everyone. Another thing is that anuria, when ureter is blocked, if it is ligated, there is a study. If you ligate the ureter, that patient can survive even 97 days. How?
with bilateral
With bilateral time, even time, no way of persevering. But there is a record that patient survived for 97 days. But how will I explain it? Explanation is that during block, the ureter will build up in the system. Due to high pressure, that urine will leak into the extra renal tissue. Through the lymphatics, it will drain to the outside. In that way,
That is another way of support to the line. Due to back pressure, urine will leak from the renal capsule. It will go to the extra renal area. It will be reabsorbed by the